Hello, everyone. Welcome to another episode of Learning on Smart Nursing. And we want to talk about primary survey, a very smart way in identifying life threatening conditions and trauma and intervening appropriately. Use the acronym ABCDE in primary survey. And so let's just look at ABCDE and what they stand for. So for ABCDE, your A stands for airway and spine control. Your B stands for breathing. Your C stands for circulation and bleeding control. Then your D is disability and E is exposure. Okay, so what do we do at these places? During airway or at A, you're assessing the airway of the patient. So what are some of the ways in assessing the airway of the patient? Now, at every point in time during your primary survey, you look, you listen, and you feel. Okay, you look, you listen, and you feel. When you are airway, you look, listen, feel. When you are breathing, you look, listen, feel. Just like that, all throughout to the E. Maybe there are some places that you may have to listen more than you look. By the end of the day, all these principles come to play. All right, so let's look at A, airway. How do we assess our airway? Okay, so at airway and spine protection, what is the main aim here? What is your objective when you are assessing the airway or when you are at A? Your objective here is to keep the airway open and protected, and you also want to protect the cervical spine. Okay, you want to keep your airway open and protected, and you want to keep your cervical spine also protected. Keeping your airway protected means that you are protecting the airway or preventing any future aspirations. Okay, if your patient is not conscious enough or there's some risks that can cause the airway to be compromised, you want to make sure that you rule that out, or you want to make sure you intervene when you see anything like that. Okay, so at airway, your aim here is to keep the airway open, and you also want to keep the C spine or cervical spine protected. So how do you do that? You look for obvious signs of obstruction. Okay, open the patient's airway. First of all, you need to talk to the patient to ask few questions. Ask the patient's name. Mr. How are you doing? What is your name? Where you are? What time is it? Try to engage the patient in a conversation. If the patient is able to complete a full sentence without stress, then your airway is okay. Your airway is open. Your airway for that moment is protected. Okay, one thing about primary survey is that you keep reassessing as you go. So even if it's okay now, it might not be okay in some minutes time. So you go ahead and you come back and reassess your airway. So at airway, you first need to talk to your patient, engage him or her in a conversation and see if the patient will be able to answer you without stress. If she does that or he does that, then for now your airway is okay. Okay, aside that, you look inside the airway to see if there are any secretions. Are there any loose dentures or any loose tooth that may be blocking the airway? You look for that. Okay, any sign of bleeding, any sign of drooling, any sign of sputum, or any foreign material in the airway, you need to look for that. All right. Then you also need to listen to see if you will hear any signs of airway obstruction like stridor, like wonkai, like gurgling sounds, okay, like wheezing, any sign of airway obstruction. During airway assessment or A, you need to listen for that. All right. Now, when you see any of these things and you want to open the airway, there are maneuvers that you can use. There are maneuvers that you can use, and these are some of the interventions that you can do at airway. If you want to open the airway, we have the head tilt, chin lift, and then we have jaw thrust. But if you're suspecting a cervical injury, then you don't do head tilt and chin lift. Okay. If you're suspecting a cervical injury, you don't do head tilt. Okay, head tilt is when you tilt the patient's head this way. Okay, and so you may put pressure on the cervical spine when you do that. So when you suspect cervical spine injury, you don't do the head tilt. Okay, you rather do the jaw thrust, that also opens the airway. All right. Aside that, you also need to put in airway agents if the need be. We have the oropharyngeal airways, we have the nasopharyngeal airways. You need to have them available so that when you need to open the patient's airway with that, then you use it. You need to also stabilize the C-spine with your cervical collar or according to the patient's size. We have them in sizes, even the oropharyngeal and the nasopharyngeal are in sizes. So you need to pick the right size for the patient and then you apply that color for the patient. Okay, so basically at airway, your main aim here is to maintain the patency of the airway and you also want to protect it. Then you also want to protect or stabilize your cervical spine by applying your cervical collar. When you see any problem, you want to open the airway, you can do your head tilt or chin lift. Okay, but in trauma cases or in cases where you suspect cervical spine injury, you don't do the head tilt. You rather do the jaw thrust. Okay, all right. Okay, so when you are okay with A, and then maybe you identified some problems and you intervened, then you go continue and go to B. Okay. All right, so your main aim at breathing is to support adequate ventilation and oxygenation. Okay, this is your main aim. When you get to B, this is your main aim. You want to maintain or support adequate ventilation and oxygenation. Okay, so here we look, we listen, and we feel. So what will you look for? You're going to look at the rise and fall of the chest as to whether it is symmetrical. You know, when we are breathing, both the left and the right side of the chest wall is to go up and down symmetrically or simultaneously. So you want to see if that is happening. Okay, you want to see whether there are any paradoxical chest movements or there are some chest indrawings or some part of the chest doesn't move when the others are moving. All those things are very, very important. Okay, you're looking to see if there is any obvious wound or any obvious bleeding anywhere on the chest. Anytime you are look for signs of bleeding, okay, under the skin, look for signs of penetrations, okay, very, very important. And you also have to bear in mind that the chest or the thoracic cavity is both anterior and posterior. There's also a posterior aspect of the chest. So anything you look for or do in front of the chest, you have to do the same at the back of the chest. When you get to breathing, you look for all the signs, whether the chest is rising symmetrically, are there any injuries, are there any bleeding, are there any obvious paradoxical movements. Very, very important. Then you go ahead and then you listen. Okay, when you want to listen, you are listening for heart sounds and you're listening for lung sounds. Okay, how is the air entry? How is the breath sounds? Are there any adventitious sounds? Are there any added sounds? Listen to the heart sounds. Okay, are they sounding normally? Are they muffled? How is it? You have to listen to all those things. Now, when you're feeling for tracheal centrality. Okay, you want to see whether the trachea is central enough. Okay, use your hand, palpate the trachea and see if it is central. All right, if the trachea is not central, where is it deviated towards? Then you go ahead, you percuss your chest. When you are percussing, you're paying attention to your percussion notes. Are they dull? Are they hyperresonance? Because any of them could lead you to a diagnosis. If it's dull, maybe you're dealing with a hemothorax. And if it's hyperresonance, then you may be dealing with a tension pneumothorax. Okay. Also are feeling. You're feeling the ribs. Okay. You are palpating the chest wall, feeling the ribs, okay, to see if they are all full continuum. Okay, it has to be continuum anyway. Is there any break anywhere? Is there any crepitus or maybe some subcutaneous emphysema? You need to palpate the chest wall to look at all those things. Okay, you are paying attention to your respiratory rate also at this point. And you're also paying attention to your SpO2 at this point because remember, it's about ventilation and then oxygenation. So you check your SpO2, you know the rate, You check your respiratory rate, you know the rate. You palpate your chest wall, feel for any crepitus, feel for any subcutaneous emphysema. You also need to feel for your trachea, look at the chest wall. Is it rising well? Is it not rising well? Listen to your heart sounds. Okay, listen to your lung sounds. Now, when you're done with B and you feel that you are comfortable, then you go ahead and reassess A. Okay, but when you find any problem at B, then you need to intervene before you go ahead. If you find any problem, maybe your trachea was deviated, okay, to a particular part of the chest wall, and then there was a hyperresonance, opposite to that deviation, coupled with some other findings that you did. Maybe your heart sounds were more, you quickly need to do your needle decompression because this could be a tension pneumothorax. Okay, so you want to do your needle decompression quickly to solve that issue. Or maybe you saw a downness. On percussion node, there was downness. Maybe SpO2 was down. Maybe respiration is giving you a problem that you're suspecting a hemothorax. Then you quickly need to put in your chest tube. Okay, so these are some of the interventions that you can also do at breathing. You can also set up oxygen, obviously. So when your SpO2 is lower than normal. Okay, so as and when you find any problem, you treat. That is the beauty about primary survey. It's about acute findings and then intervening. You are not paying attention to maybe detailed things, but you are looking at what can kill you right now. So immediately you find, you intervene before you proceed. If your breathing is not fully covered, you don't proceed to circulation. Okay, because according to evidence, airway will kill you before breathing. Breathing will kill you before circulation. So you go accordingly. Okay. So when we are done with breathing and we feel we are okay, then we go back and reassess airway. Always go back to reassess airway. If your patient was talking, check to see if the patient is still talking. Okay, if you did any intervention, check back to see if the head that you tilted is still like that. Okay, check back, make sure that your airway is still open, your airway is still patent, and your airway is still protected. So at breathing also, if you see any open wound, an open pneumothorax, a wound that is, you can see bubbling, you see air bubbles inside, that is moving with respiration and all that, and you suspect that this is an open chest wound, you put in your three-way dressing, tape it at tray size to create a one-way valve so the patient will not go into tension. Okay, and you are good to go. So if you are comfortable with your breathing, then you continue to C. And then C is circulation and hemorrhage control. Okay, C is circulation and hemorrhage control. So your main objective, your main aim at C is to maintain adequate tissue perfusion and control excessive bleeding as much as possible. So your main aim here is to what? Maintain adequate tissue perfusion. Okay, so here you're also looking, you're listening, and you're feeling. So what are you looking for? Obvious signs of bleeding, obvious external bleeding. Is there any wound somewhere that is bleeding profusely? Okay, that is what you are looking for here. And then you quickly arrest the hemorrhage. Okay, what else are you looking for? The cooling sign and the great tenderness sign, which will lead you to maybe a splenic rupture of a sort or something causing internal bleeding inside your patient. Now you check your pulses, you check your BP. Okay, you check your capillary refill, tissue perfusion, check your capillary refill to see if it is normal. Is it less than 3 seconds? You want to look at all these things. Okay, now when your capillary refill is delayed, then your patient may be in shock. When you check your pulses and then it is high, tachycardia coupled with other signs and symptoms like maybe some bleeding, obviously, and maybe some altered mental status, which probably you have not seen yet, but with your tachycardia and obvious bleeding, your patient may be in shock and you need to intervene. Quickly put your large bore cannulas inside, two, one here, and start your IV crystalloids. Warm crystalloids preferred at this point. Okay, so at circulation and hemorrhage control, the objective here is to maintain adequate tissue perfusion. Okay, then you want to also control the bleeding. So if there's any external bleeding, make sure you apply your pressure dressing and then you arrest the hemorrhage. Okay, the patient is having signs of shock, capillary refill time is delayed, there is tachycardia, is bleeding, then you put in your large bore IV cannulas and you start your infusion. Okay, this is very, very important at circulation. Okay, so you're looking, you're feeling, and then you are also listening. Okay, now let's go back. You have to go back, reassess your A, reassess your B, come back to C, and then you proceed to D. Okay, this is smart nursing. As always, if you have watched us so far, thank you so much for watching. Thank you so much for always supporting us. Thank you so much for always encouraging us to keep giving you videos. So today we are dealing with primary survey. We've done A, we've done B, C. Now let's look at D. When we get to D, we are doing a rapid neurological assessment. We are seeing the mental status of your patient. Rapid, okay. You remember we said this is primary survey. We don't have time, so you do a rapid one. Okay, this is where we use our AVPU score. Okay, whether the patient is alert, is the patient responding to voice, is the patient responding to pain, or the patient is unresponsive. This is where you do that. You quickly assess your patient's, mental status. Okay, this is where you check pupils equal, are they reactive to light, are they round, okay, are they convergent. This is where you do that and you pay attention to it, whether or not one pupil is bigger than the other, what we call anisocoria, which could tell you that there's a bleed ongoing in your brain or there's something hidden, there's something hiding there, there's a foreign body hiding there. This is where you pay attention to it. Very, very important. You're doing quick neurological assessment. Okay, you want to see if there are any lateralizing signs. Okay, is there any part of the body that the patient is not moving? This is where you pay attention to it. You also check your blood glucose. You also check your blood glucose, okay, to see if it is normal or not. Because if it's about head injury at this point, then you are concerned for glucose, you're concerned for oxygen. Okay, you don't want your patient to have a secondary brain damage or a secondary brain insult. There's already been an insult to the brain, so you want to control that as adequately as possible. You want to make sure that you're perfusing your patient right, you're oxygenating the patient right, make sure glucose is also fine. So this is where you check your blood glucose, and then if you need to intervene with some glucose or dextrose infusion, then you do that. Okay, so we have done our A, we've done our B, our C, we are on D. We want to continue to exposure, but we have to go back, reassess our airway and cervical spine, reassess our breathing, reassess our circulation and breathing control, come back to our disability, check our AVPU again, look at the mental status, look at the glucose, look at pupils. Okay, look at the mental status of this patient, and then we can continue to E, which is exposure. When you are disability also, and then you suspect that your patient's, you know, GCS, maybe you didn't do an AVPU, but you did a Glasgow coma scale, you were able to do that quickly, and your patient's GCS is less than 8, then your patient has a severe head injury, and then you need to consider intubation, or you need to intubate this patient at this point, because a GCS less than 8 means that the patient's airway is not protected. This patient can aspirate at any time. So you need to intervene quickly. Okay, when there is hypoxia, need to make sure that your oxygenation is on point. If there is hypoglycemia, you need to make sure that you correct it by giving glucose. Okay, so when you're done with all this intervention, go back to assess your A, your B, your C, and your D. Then you come to exposure. E is actually exposure and then environmental control. Okay, so you expose your patient to assess the body, okay, whilst also maintaining warmth. So whilst you're exposing the patient, make sure that you don't expose the person too much to the environment, which could lead to hypothermia, which will now continue to give you some hypercoagulability, and then your patient may worsen. Okay, so you expose your patient, you observe the skin for any other hidden injuries, log roll this patient. Okay, and check the spine for step ups. Look at the back for any hidden injuries. Okay, feel for any crepitus. Feel the rest of the body to see if the bones are continuous, everything is continuous. Check the temperature. Okay, check your temperature here. Continue to give your warm IV fluid. Keep your patient warm even though you have exposed your patient. Okay, because most at times you forget to check the back of the patient. So during exposure, we remove everything, do a complete scan of the body with your eyes from head to toe. Turn the patient, look at the back, see if there are any injuries, do your step offs, okay, to see if all the spines are in order or if the patient is feeling tenderness or pain anywhere. Okay, now when you are done with all these things, go back and assess your airway. Okay, go back, assess your breathing, go back, assess your circulation, go back, assess your disability, and then you come now to exposure. So by the time you finish doing all these things, doing this step by step, you might have stabilized your patient. You might have identified problems because that is the main anyway. Identify problems and you might have intervened already. Then you will now move to what we call secondary survey. Okay, so what are some of the key principles of primary survey? What are some of the things that we should note about primary survey? The key principles of primary survey here is to note that you need to keep reassessing your patient whilst you are at it. Whilst the patient is with you, keep reassessing your patient. Don't just stop there. Okay, you have to go back because, like I said, things might change at A when you were at B that you don't know. So you always have to go back and reassess. Okay, anytime you find a problem, intervene before you proceed. There is a reason why it is structured that way for you to do your airway, your breathing, your circulation, your disability, and your exposure. So anytime you find a problem at airway, don't say, okay, let me finish before I come back. No, don't say, let me go through all the procedure, the ABCDE before I come back. No, intervene before you proceed. Okay, intervene before you proceed. That is one key principle about primary survey, and that is the beauty of it. When you do it systematically, you will not miss any life-threatening problem. You will sort your patient, you will save that patient. Then you will now have time and do what we call secondary survey. That is a complete head-to-toe assessment, examinations, details of history. That is where you pay attention to some things that maybe you didn't see during the primary survey, but they are not things that are so life threatening. Okay, so that is the beauty of primary survey. So what have we been talking about today? Today we spoke about primary survey. We said that it is a quick systematic way of identifying life threatening conditions and trauma and then intervening as you move forward. Okay, and then we said that we use the ABCD approach where A stands for airway and then cervical spine control. Very, very important. Make sure that you always protect your cervical spine until it is proven okay. If you don't have imaging or you haven't done imaging yet, utilize this patient. If you can, put your cervical spine, put your blocks, put your tape, and do the tripod immobilization. That actually keeps your cervical spine under control. Okay, feel for any step off on the head, on the skull during your airway that could lead you to some maybe fracture of your airway. Palpate the face, feel when you are feeling, palpate the face around here to see if you feel any crepitus that will be suggestive of a subcutaneous emphysema, which could mean that you might have some sinuses getting broken over here. Okay, open the airway when you're looking. Are there any obvious things that you can remove? Are there any secretions? Are there any foreign bodies in the airway? Look at that and remove them if there is any. Then you listen to the sounds and see if you can hear any sound of airway obstruction, which will need that you need to intervene. Maybe there's a wheeze, there's an gargling sound, or there is a stride, or pay attention to the breath sounds. Okay, if you need to do your maneuvers, your head tilt and your chin lift is there. If the you're not worried about your patient's cervical spine, your head tilt and your chin lift is there. But if you're worried, please don't do head tilt or chin lift because you will put pressure on the cervical spine. Then you can do your jaw thrust if you also want to. Your airway adjuncts are there, your oropharyngeal and your nasopharyngeals, they are very handy. If you need to do that, look for the right sizes and then you give that to your patient. If you're okay with your airway, then you move to your breathing. At breathing, you're looking for the rise and fall of the chest. You're looking for any obvious signs, of injury. Is there any open wounds over there? Communicating with the environment and then your pleural space. Pay attention to that. How is the chest movement? Are there some segments that are not moving and others are moving? Maybe there's a flail chest over there. You pay attention. Okay, palpate your trachea. Is your trachea central? If it's not central, where is it deviated towards? Pay attention to that. You do your percussion notes. Are they dull? Are they hyperresonant? Okay. Am I having a hemothorax or I'm having a pneumothorax? If I'm having a pneumothorax, am I having a tension pneumothorax? Put all that together after you've done your auscultation. Also, you've listened to your air entry, your breath sounds, and then you suspect that you may be having some tension pneumothorax. Quickly go in, do your needle decompression, and then you are good to go. And when you're done with your breathing, after you've assessed your respiration, your SpO2, and everything seems to be in the normal range, go back and assess your airway. Always remember to go back and assess your airway. Your airway is fine, breathing is fine. You come back to circulation where you are doing, circulation and then hemorrhage control. So look at your pulses, look at your BP, look at your capillary refill. Okay, if you suspect a shock, put in your large bore cannulas, hang your IV fluid, your IV crystalloids. Warm crystalloids are preferable. Okay, do that and then you go back, assess your A breathing. If it's fine and C is fine, go to disability. Quickly do quick neurological assessment. Look at your GCS if you can. If you cannot, do your AVPU. Okay, check your sugars and also check your papillary reactivity. Are both pupils round? Are they equal? Are they reacting to light? Are they convergence? Pay attention to all those things. Now, when all things are done and they are fine, go back, assess your ABCD, then come to exposure, where you're doing exposure and then environmental control. Expose the patient, paying attention to temperature. Okay, don't let your patient go hypothermic. While you're exposing, be covering some parts as well. Observe every part of the body, front and back, for hidden injuries. Check your temperatures, okay? Give your patient warmth because in trauma, you are concerned about hypothermia, which you don't want. So, this has been Smart Nursing. Watch out for our next video when we talk about secondary survey in trauma. Thank you so much for watching.